Hello, my dear students. I hope your journey was very smooth with respect to INI-CET November 2024 exams. After a long wait, you all have given that exam. Some of you might be flying now because you have done wonderfully well, but some of you might have not given 100% to your potential. So this is the time when you have to reset with those questions and then look into, analyze them so that the mistakes won't repeat. Second thing is you are learning from the mistake. And third thing is definitely you will get to know the potential questions for your future exams so that your preparation is going to be good. I, Dr. Ranjana Ranade from Manipal MedAce, will be discussing pathology questions with you today. So without wasting much time, let's get into the discussion now. The type of the questions, I would say that they were more of general pathology and hematopathology questions when compared to that of systemic pathology. The repeats were there, but they were asked in a different way. I would say that about 30% of the questions, yes, there was a repetition. The difficulty level was moderate. Some were very, very easy. They were like one-liners, right? They were purely recall-based questions and one-liners. So let's look into the questions. Which of the following is not a component of MEN2B? So this is purely recall. You know that MEN2 is MEN2A as well as MEN2B. And in MEN2B, marfanoid habitus is there, mucosal neuroma is there, medullary carcinoma of thyroid. This is common to both MEN2A as well as MEN2B. So what is not looking or seemingly fit into MEN2B is parathyroid hyperplasia, and this is the correct answer. Okay. Now, if you look into my notes as well as the lecture videos, you can clearly see that I have given an indication that MEN2A and MEN2B both will have medullary carcinoma of thyroid, and then you have pheochromocytomas as well as neuroma, ganglioneuroma, marfanoid habitus. All those are components of MEN2B. There also I have compared between the MEN1, MEN2A and MEN2B syndromes. You can see the components under MEN1, MEN2A and MEN2B. So students, please do not ignore this topic because this can be asked. Now this time it is MEN2B, next time it can be MEN4 or MEN1. Okay. Now in MEN2A, if you see, there is parathyroid hyperplasia along with medullary carcinoma as well as your pheochromocytoma. Okay, MEN2B is more aggressive. There is red gene mutation, but here you can see ganglioneuromas, mucosal neuromas, marfanoid habitus, all are components of your MEN2B. Moving on to the next question. Which of the following is not a germ cell tumor of ovary? This is a pretty simple question. If you know, dysgerminoma, yolk sac tumor, choriocarcinoma, all are what? Germ cell tumors of ovary, GCTs. Whereas whether it is an adult granulosa cell tumor or juvenile granulosa cell tumor, moment you see granulosa cell tumor, you know that that is a sex cord stromal tumor. Sex cord stromal tumor. Thecoma, fibroma, granulosa cell tumor, all those come under your sex cord stromal tumor. Dysgerminoma, teratoma, yolk sac tumor, embryonal carcinoma, choriocarcinoma are all under germ cell tumor. This is a very straightforward question. You need to be just familiar with the classification of ovarian tumor to answer this question. Okay, starting from surface epithelial tumors, then sex cord stromal tumors, germ cell tumors, metastasis. This is a page from my own notes in the app. So please look into it and do not get confused. And once you remember the germ cell tumors for ovary, same things are going to be there for testis also, except for your dysgerminoma, which we call it as seminoma, and there is an addition in the form of spermatocytic seminoma, right? Moving on to the next question. Which says epithelial mesenchymal transition is mediated by which of the following factors? I'm very sure that this is a new question here. So moment you see epithelial mesenchymal transition, you should remember that this is the mechanism which is involved in invasion and metastasis. Invasion and metastasis of malignant tumors. So that they have a potential to have that cytoskeletal activity. Then they invade, they break the collagen matrix with the aid of even matrix metalloproteinases. So this EMT is very essential, and that gives them a potential of metastasis. I have discussed in my notes as well as in lecture that snail and twist are the genes which are implicated in metastasis of various malignant tumors. Whereas HNF1 alpha, it is called as a scatter factor. Also, it is implicated in the pathogenesis of hepatic adenomas. This, that they are expressed in lung tumors and the tumors which are originating in thyroid, that is TTF1. Whereas matrix metalloproteinases, it helps in the breakage of that basement membrane and the collagen which is surrounding the tumor, but not exactly with your EMT. Okay, that is epithelial mesenchymal transition. So this is given in my notes also. You can have a look into that. So for EMT to happen, there is a loss of E-cadherin that should happen. So there is reduced expression of E-cadherin gene, so that the cell-to-cell attachment becomes loosened and there is detachment of cells. So there are some genes which favor metastasis, include snail, twist, rage, MTA1. So this is what is very, very important. And also there are genes which can suppress metastasis, right? This is a new question. So you should be careful about the newer things which are being asked, and you can expect some newer questions in the form of the genes which suppress metastasis in the future exam. Which of the following HLA gene is associated with ankylosing spondylitis? Or some students said, the question just said that it is sacroiliitis plus uveitis. Even that is the case, you know that you are dealing with ankylosing spondylitis. So this is a pure recall related question. So naturally HLA-B27 is the correct answer. So what is one important thing while dealing with MCQ is, once you know the right answer, do not look into the distractors, because this will create problems in choosing the correct answer. Okay, when you have a lot of options in front of you, you go confused, but when you know the correct answer, one definitive answer, do not look into other options when you are asked to give a single best answer for the particular question. So in this case, HLA-B27 is the correct answer. DQ8, you know that it is for celiac disease, DR4 is for rheumatoid arthritis. So this is a table which is there even in my notes. You can look into it. So HLA-DR-B1 as well as DR4 is for rheumatoid arthritis. HLA-B27, that is for ankylosing spondylitis. HLA-DQ-A1 as well as you have DQ2 as well as DQ8, that is for celiac disease. Moving on to the next question. Which of the following is seen in acute pancreatitis? So the options goes like this. I have got only 3 options. I request you to give one more option here. The options goes like this. Lipase is more specific than amylase. Yes, it sounds correct. Then lipase requires 30 days to return to baseline. This we have studied that it requires at least 2 weeks to go to baseline. Lipase reflects severity. That's not the correct answer. Lipase is not a good reflector of severity. It is said that CRP rather is a good reflector of severity. So if you look into my notes, you can see that the first 4 to 24 hours there is increase in serum amylase, and that goes to normal in 5 days. Serum lipase, which is more specific and sensitive, and it remains elevated up to 2 weeks. Okay, not it takes month to go back to normal. And C-reactive protein is the one by which you can assess the severity better than these 2 things. Now, considering only 3 options, what is the best option that you can pick up and true in case of acute pancreatitis is, it is more specific, and people say that it is more sensitive also. Lipase is more specific when compared to that of amylase. That is the correct option. Moving on to the next question. Identify the structure in the given image. So it's a pretty, they have used a trick. It's a tricky image, looks very beautiful, that is a concentrated amorphous pinkish material which is there inside the glandular lumen. So it is very important to appreciate that you are seeing this structure within the gland, and you know that they are not bluish or basophilic in nature, so that you don't get confused with calcification. So because they are not calcific or bluish or basophilic in nature, please exclude this. That is psammoma bodies, easy. And then amyloid, you expect it to be pale, waxy, and you expect it to be outside the cell, right, in the interstitium, somewhere here, not in the lumen like this. So amyloid is also out, pale extracellular amorphous eosinophilic deposits. Okay. Then corpus luteum, where do you expect that? Is in the ovarian, not like this. You have a foamy cytoplasm, abundant foamy kind of cytoplasm, because it's all filled with a lipid. That's in the ovary. Now, you don't see something like glandular structure there. So, what you are left with is corpora amylacia. Moment you see this fibromuscular tissue as well as glands with laminated eosinophilic secretions, you are actually dealing with corpora amylacia, which is seen in normal prostate as well as in conditions like benign prostatic hyperplasia. Okay. So here is the glimpses of my notes, wherein I have described these eosinophilic secretions which are there within the glands as corpora amylacia, as you can see here. So the key is to identify the prostatic tissue, not to go confused with amyloid, but that is also pink, but it is pale and it is not laminated like how it was in this case. Okay, it will not show layers like this. The only thing which you can get confused is psammoma bodies, but you don't expect to see within the lumen of the gland, number one, and you expect to see it as basophilic, bluish, okay, very dense bluish, not pinkish like this. The moment you identify these glands and fibromuscular tissue outside, yes, you are dealing with prostate. So the correct answer is corpora amylacia. Next is again a simple recall question. Which of the following change describes sickle cell anemia? I remember from first year of MBBS, okay, that is beta 6 position, and the teacher told me that valine is waste. So valine should be there, and that is waste. Now it is replacing glutamic acid. So what is the correct answer? Substitution of glutamic acid by valine at beta chain 6th position in the beta chain of hemoglobin. So moment you get the right answer, there is no need to look into the other answer, because only one answer can be correct in this case. So that's why option A is correct in this particular case. Moving on to the next question. All are hereditary causes of thrombosis. Very straightforward. It's like a cakewalk. These questions you can easily score, and students, you should not miss on these questions, right? So whenever we define PNH, paroxysmal nocturnal hemoglobinuria, we always say that this is the only acquired genetic defect, and that results in hemolysis. So protein C is inherited, antithrombin 3 is inherited, homocystinemia is also inherited. All these are inherited, but what is acquired is PNH. Okay, so again in my notes, if you look into this, the first sentence itself, the only intrinsic cause of hemolytic anemia which is caused by acquired genetic defect with respect to PIGA gene, and there is deficiency of CD55 as well as CD59, and you have to do a flow cytometry for confirmation of the diagnosis. There is nothing required. If you have read once or twice and remember it as acquired, you will be able to do this correctly. Next is, which of the following is the most common inherited cause of thrombosis? Again, one-liner. Moment you see lead-in mutation, factor V mutation, there is no need to look into other options in this. It's a straightforward one-liner. Most common genetic cause of hypercoagulable state. It's there in my notes also. This is from my notes, factor V mutation. Okay. So that is the correct answer. If they have given you lead-in mutation, even that is correct. So once it is mutated, this particular factor becomes resistant to the protein C activation. It doesn't undergo protein C mediated lysis. So it leads to more and more of thrombin generation, and hence the patient becomes susceptible for deep vein thrombosis. Next question, which of the following is not a part of TTP, thrombotic thrombocytopenic purpura, where I always ask my student to remember the pentad, right? So there is thrombotic thrombocytopenic purpura. What they have used in the option is thrombosis, okay? What is MAHA? That is microangiopathic hemolytic anemia. So this is always there. Acute renal failure, yes, it is there. Thrombocytopenia is also there. Now what is not there is you don't have macrovascular thrombosis. You actually have the small fibrin thrombi which is there in the glomerular capillaries, okay, involving the very small vessels. So thrombosis is typically not a feature of thrombotic thrombocytopenic purpura. So again, glimpses from the notes here. So TTP is a pentad of microangiopathic hemolytic anemia. There is thrombocytopenia. There is acute renal failure. Patient will have fever and neurological symptoms, which makes it different from hemolytic uremic syndrome. Both of them will have a picture of microangiopathic hemolytic anemia. So option could be even in that way, where they say that schistocytes or fragmented red cells are present in the peripheral smear. Okay. So this is one important thing that you have to concentrate, and also they can even write there was deficiency of ADAMTS 13 in thrombotic thrombocytopenic purpura. So if you look at this carefully, there is no thrombosis which is given here. So because you don't expect the large vessel thrombosis is a manifestation of TTP, that is not a typical feature of TTP. Moving on to the simple match the following question here. Some students said it was, many students actually said 4 to 4, but 1 or 2 students also said there was HNPCC also. So I included everything. Peutz-Jeghers syndrome, so this is the perfect match. STIC11 or LKB1 mutation, and that's usually autosomal dominant in nature. Familial adenomatous polyposis is for APC gene mutation. HNPCC, you know that there is microsatellite instability, so naturally you will think of DNA repair. Tuberous sclerosis, TSC, is a gene which is associated. Juvenile polyposis is usually the SMAD gene mutation. A simple, straightforward match the following question, which just requires some amount of revision and recall. Nothing more than that is the type of this question. Next is, again, I always tell my students to remember there are a lot of mnemonics that I have given even in the rapid revision classes. They are there in my notes. They are there in the video content of Manipal MedAce. You can see that no one can escape from these Mendelian disorders and disorders with non-classic pattern of inheritance in pathology. In all exams, they keep repeating in different fashion. This time there was no pedigree, but then simple match the following question. So cystic fibrosis is autosomal recessive. How about DMD? Is X-linked recessive. Becker's and Duchenne. Then Leber hereditary optic is mitochondrial inheritance, and SCA or spinocerebellar ataxia is with a trinucleotide repeat mutations. Students, I urge you to go through these mnemonics again and again for autosomal dominant, autosomal recessive, as well as for your X-linked recessive, which is very easy, right? You have A, B, C, D, E, F, G, H till then. And then mitochondrial inheritance, where you have to be even familiar with the pedigree. And lastly, these are trinucleotide repeat mutations starting from Fragile X syndrome, Friedreich's ataxia, myotonic dystrophy, spinobulbar muscular atrophy, Huntington's disease, and spinocerebellar ataxias. Moving on to the next question. Here it says, which of the following vacutainer is used for serum electrolyte estimation? Even if you don't know what is used for electrolyte estimation, moment you say the serum, okay, so you should be knowing that for any kind of serum related estimations, either you have to use the red topped vacutainer or yellow top vacutainer, correct? You don't require any anticoagulant to be present because you need serum, right? So this lavender will have EDTA that is used for your CBC estimations, and then green is for heparin, right, where you would look for blood gas analysis, and if you're sending the sample for flow cytometry, naturally you would prefer this. And gray is for your blood glucose estimation. So for this, the correct answer is yellow. Again, this is a high yield area, right? You can't go to exam without reading this, and you have to use common sense. When they're not asking a straightforward question, this time they asked electrolytes, but they mentioned serum electrolytes. So it's very easy to pick up the answer. Okay, so this is the content from my notes where I have explained different vacutainers, what are the uses of the same, and also we have mentioned like what are the problems with heparin. Why don't we use the other vacutainers for blood glucose? Why only we prefer sodium fluoride? And also you will get the ratio of the anticoagulant versus the blood. So you can see it here. And also one time they had asked the question on the order of blood draw. Okay. For one patient, you have to send the multiple tests, then what should be the order? So there is a mnemonic also. Blue river goes little gray, and you can expect again in the next exam. So be familiar with all these things. The component of Carney complex includes all. This is one thing which we don't very keenly, cover in pathology. Many of the students said there was a name acronym. NAME is the acronym, which usually gives the components of Carney complex, and they wanted this acronym where they said N is for nevi, A for atrial myxoma, M for mucinosis of the skin, and E for Epstein anomaly. Moment you see this Epstein anomaly, which is because of your tricuspid valve defect, you should be little careful. Even if you have not read these components, okay? You know that Carney syndrome you have studied when you are reading about pheochromocytoma. You have studied in many of the endocrinopathies. You have studied it as the thyroid tumor related things, and you have studied in association with lung tumors. So basically when you know that thyroid, adrenal gland, all these are associated, this is E is for endocrinopathy. Endocrinopathy, and to confuse you, they have given Epstein anomaly, and that is the correct answer in this particular case. Okay. Which of the following is not associated with celiac disease? Pretty easy. Just look into the option. The moment you see HLA-DQ11, you know some problem is there. Okay, let's look into other options. IgA transglutaminase, anti-tissue transglutaminase antibody, which is of IgA type, correct. Marsh grading is used for grading the villus atrophy, that is also correct. Anti-gliadin antibodies, anti-endomysial antibodies are also seen in this case, that is also correct. Now, you know that there is some problem with this. If your recall is really good, you know that DQ2, DQ8 is associated with celiac disease and not DQ11. So the minute you see this, no need to look into option. If it is a single response type of question, then the correct answer here is HLA DQ11. Now this is a content again from the notes which is uploaded in the app. You can see here the HLA which is asked in this question is addressed here. The antibodies, tissue transglutaminase, anti-endomysial antibodies, everything is mentioned here. And even I have put a word on Marsh grading. Though we teach postgraduates this, Marsh grading of villus atrophy. Just to complete the information, I have given it in my notes. If you have read this, definitely you will not have confusion on whether to include Marsh grading or exclude Marsh grading. So that is used in grading your biopsies of celiac disease patients. Next question, which of the following cancers can be prevented by vaccines? So this is an indirect question based on your biological carcinogenesis topic. So here the etiologic agent for carcinoma cervix is HPV. For hepatocellular carcinoma, it is hepatitis C virus and hepatitis B virus. Burkitt lymphoma, it is Epstein-Barr virus. And for Merkel cell carcinoma, it is Merkel cell polyoma virus, right? So till date, we have vaccines which work against human papilloma virus and also against hepatitis B. So these can be prevented by vaccination. So if it is a multiple response kind of question, then naturally the answer should be your carcinoma cervix and hepatocellular carcinoma. EBV, against EBV we don't have a vaccine, and Merkel cell carcinoma also, for this virus we don't have a vaccine. So these two become the correct answer. Next is a patient with history of gastrectomy. There is a keyword. So pick up this keyword. There is gastrectomy. And patient has some neurologic problem, but some students said subacute combined degeneration was also there in the history. Now straight away they're asking what vitamin deficiency. You have intrinsic factor deficiency when gastrectomy is done, IF, intrinsic factor. So naturally straight away answer this question as B12. Do not look into all other things unnecessarily in this particular question. Okay, a very simple comprehension type of question. Next is a 45-year-old female. Fingers are turning pale blue red. There is some play of colors and exposure to cold. There is difficulty in swallowing. There is telangiectasia. Basically, they are talking about a syndrome with some components in a middle-aged female. And there are cold fingers, tight skin. Immunofluorescence is given to you and you need to identify the pattern. So there is some kind of stars in the sky. Okay, you can see multiple dots. Moment you see this dot, it is speckled pattern. But once you see this, okay, where it is highlighting the mitotic activity, immediately you should change the pattern to a centromere pattern. Speckled is the most non-specific pattern and the most common pattern which is observed when you do this immunofluorescence. But because this is there, okay, so you will have to shift this plus this. So that becomes your anti-centromeric pattern or the centromeric pattern because of anti-centromere antibodies. Now centromeric pattern, you have got it in the option. So they have given the disease. Scleroderma, yes, the localized form of systemic sclerosis, if you are thinking, correct. But it is not nuclear positive. It's not like the nuclear pattern that you expect in systemic lupus erythematosus. And the history is not suggestive of SLE where they would give you malar rash, joint pain, etc. Then we are also not dealing with the history where there is bilateral enlargement of salivary glands, which will go with Sjogren's syndrome. Now what we are left with is to think it as the scleroderma with you pattern is confirmed, that is anti-centromere antibodies. Luckily in none of the other options have this, right? The combination, the perfect combination which will become correct is scleroderma with centromeric pattern, and hence this is the correct answer. So go back to my notes again, appreciate this is the diffuse pattern, this is the rim pattern, and here we have the speckled pattern. And if we see speckled with this highlighting the mitosis, then you have to think of centromeric pattern, okay? And they exist in different conditions. When you see this diffuse pattern, all of you will be happy because that's the most common thing that you encounter in systemic lupus erythematosus, and it's easy to diagnose. The entire nucleus looks very, very smudgy and it's positive, right? So this is one thing from my notes which I wanted to share. The other thing is, the moment the history is so leading that they have given you there is difficulty in swallowing, telling that there is esophageal motility, there is Raynaud phenomenon, there is telangiectasia, there is tight skin, everything they have given. Actually they are telling you about CREST syndrome, which is limited scleroderma. And in limited scleroderma, what you see is anti-centromere antibody. So this is how you can approach this particular question. And if it is in the diffuse form, you will get what is known as anti-SCL70 antibody. Clear? Next is a simple match the following tumor with the biomarkers. Alpha fetoprotein. If you are expecting hepatocellular carcinoma, that's not wrong, but here the option provided was hepatoblastoma. Then beta HCG, choriocarcinoma, both in gestational as well as in non-gestational. Calcitonin in medullary carcinoma of thyroid. Catecholamine, or sometimes they can give you as vanillyl mandelic acid. Naturally, that's a biomarker in pheochromocytoma. So this is also one of the important and very easy to score kind of question, which we have discussed a number of times. Which of the following blood collection tube is used for HbA1c estimation? This is quite tricky. We have not discussed it directly. But yes, now let's, they have given you the anticoagulants are used in the different tubes. Sodium fluoride, you know that it is used only for blood glucose estimation, right? And the heparin, just now we discussed, it's for blood gas analysis. And also if you want to do ancillary studies like flow cytometry, you'll use it. And if you want to do coagulation studies, PT, APTT, sometimes ESR, yes, you'll use sodium citrate. Now EDTA, we always studied that it is used for complete blood count to measure your hemoglobin, yes, and for cell counts, yes, we use this EDTA. Now, if you just imagine how is the hemoglobin measured, in which container you want to send it, or the collection tube, definitely it is EDTA, right? You can use the same logic here. Now, we are studying something that is biomolecule which is conjugated with hemoglobin, for which you need to lyse the RBC. Then this is a special form of hemoglobin that you are going to estimate. So naturally use a common sense there, and here EDTA is the correct answer. So moving on to the next question. Which of the following statements are true regarding hemolysis? This is a question based on the differences between the extravascular and the intravascular hemolysis, where the option are like the ALP, that is alkaline phosphatase, is elevated, GGT is elevated. So if you are very vigilant, you can make it out that ALP is normally elevated in bone diseases and in hepatobiliary, mainly in the biliary tract diseases. GGT is usually elevated again in biliary tract disease and also in alcohol addiction. So these two are nothing to do with your hemolysis, okay? So in hemolysis, basically heme and globin, there is a breakage, and that excess of heme, right, that's going to be again further metabolized to give rise to the heme derived metabolites in the form of bile pigments. So there is indirect hyperbilirubinemia and also increased urobilinogen that you see in hemolysis. And because more and more of hemoglobin, free hemoglobin is going to get released, so that free hemoglobin is going to bind to a plasma protein called as haptoglobin. So your free serum haptoglobin levels are going to be reduced, because most of which is going to be bound to hemoglobin, right? So these two are correct, whereas these two are incorrect. Now if you look into my notes again, you can see these options, that is reduced haptoglobin levels in the serum, as you can see, and indirect hyperbilirubinemia, increased urobilinogen levels are also true for your hemolysis. So this is something very important related to your features of extravascular and intravascular hemolysis, and you can expect many types of questions based on these concepts. The next question is, patient with features of, they have already given to you that Zollinger-Ellison syndrome is there. So in Zollinger-Ellison syndrome, what is a tumor, endocrine tumor that you expect? So naturally it's a gastrin producing tumor. So the answer has to be gastrinoma in this case. This is not related to insulinomas or VIPomas. Quite straightforward question, and if you have read this one or two times, definitely Zollinger-Ellison is related to gastrinoma. There is hypergastremia in this. The gastric acid secretion is increased and severe peptic ulcer will be there, and most of these are potentially malignant, okay? Whereas the insulinoma, will be characterized by hypoglycemia. That is what we call as Whipple's triad, right? There is insulinemia and correction of glucose upon administering the glucose, and then you will see a lot of amyloid in between the tumor cells which produce apple green birefringence under polarizer. And most of the times the gastrinoma arises from the gastrinoma triangle, which is formed by the soft tissue structures of stomach and pancreas, and peptic ulcers at unusual locations, and that's when you start suspecting there are multiple, and hypergastrinemia is there. That's when you start suspecting this Zollinger-Ellison syndrome, which is because of gastrinoma producing that is gastrin producing neuroendocrine tumor, which we call as gastrinomas. And remember that they are potentially malignant, they can even metastasize. Next is very expected question is what I can say. Right forearm swelling in soft tissue. We always emphasize that schwannoma is one thing that the student has to look into the image, familiarize, see those verrucate bodies. There are hypercellular areas which are forming verrucate bodies and hypocellular areas. You can see that palisaded nuclear pattern. So, moment you see this, you know that you are dealing with schwannoma. So, schwannoma and neurofibroma are what? Peripheral nerve sheath tumors. So, this option has to be correct. Then schwannoma, yes, it is associated with neurofibromatosis too, and neurofibromas are associated with neurofibromatosis type 1. The verrucate bodies are seen in light microscopy, they are quite obvious. Now, what is a problem in this is metastasis is common, right? Metastasis is common if it is malignant. And what is a malignant counterpart? MPNST, malignant peripheral nerve sheath tumor, and not in schwannoma. It is not true for this particular image. Hence, D is the correct answer for this case. So, this is again summarizing the peripheral nerve sheath tumors from my notes. You can have a look where we have talked about schwannoma, neurofibroma as well as MPNST, which is a malignant counterpart. Next is again a simple question. 5-year-old child with gum bleeding because of thrombocytopenia. That's what you can think of. Then they have given you peripheral smear where it showed a large sized blast looking cells. Okay, you can see here, and there is high NC ratio. They have a dark chromatin, something like lymphoblast, and flow cytometry also they have given you. TDT is positive, CD19 is positive, CD10 is positive. Moment you see this TDT, okay, so these are for precursor lymphoid cells, So they are not specific for B or T cells. They are present both in B cells as well as in T cells. But what will tell you whether it is B or T is presence of this CD19 and variable positivity for CD10. If at all it is T cell, then you expect CD3 as well as CD7 to be present on them. Okay. Now, based on all this, they have given you, your job has been made very easy. Even if you don't see this, you see this, okay, 10, 19, TDT positive. TDT is either you have to go for B cell ALL or T cell ALL, lymphoblasts, okay. But then 19 is positive, so naturally it is B. So you stop there and mark the correct answer as B cell ALL for this particular question. Okay, AML you would expect to see or rods, and you don't see TDT being positive. CLL naturally you will see your the smudge cells in the peripheral smear that are missing in the peripheral smear, and of course you will expect CD5 to be positive, 23 to be positive in cases of CLL. So this is again from the notes. Here I have summarized precursor B cell, TDT positive, 19, 20 positive and CD10 variable positive. And if it is a T cell, then TDT, CD3, CD7, all this are positive. So please remember this, you will get the right answer. Next is autoimmune polyendocrinopathy is not associated with which of the following conditions. This is in the chapter of autoimmunity. If you have read the applied aspects, some of those things are also given in my notes, then it is easy. Otherwise, I would say it is little tougher, and even if you miss it for this attempt, no regrets, okay? For the next time, I think you will not do it wrong. It is AIRE, autoimmune regulator gene defect. So that sounds correct. Candidiasis. These patients usually have the skin diseases, okay, ectodermal dystrophy as well as candidiasis, and they have increased risk of type 1 diabetes, and this is a very rare condition, and that's why we don't emphasize for our undergraduate students to remember these things in detail. But onset at infancy is something which is not correct. This is commonly seen in children as well as in adolescents. Okay, so this is the age group you expected to see, and this is the one which is not correct regarding autoimmune polyendocrinopathy. Again, if you refer my notes in applied aspects under autoimmunity, I have put that autoimmune regulator. This is a gene. When there is germline loss, the patient is susceptible to develop the autoimmune polyendocrine syndromes. This results in loss of central tolerance, and because they're immunodeficient, they are more prone to develop candidiasis and ectodermal dystrophy in this particular case. Okay, so there are other autoimmune regulators which can go mutated, and they can cause a lot of syndromes, one of which is IPEX syndrome, which you can expect in the next exam. Next is, which of the following tests can detect aneuploidy? It is variation in the chromosomal number. Okay, so if you want to deal with the number, only 2 tests. This I have told in my rapid revision class also. So you have to go for FISH or karyotyping, where you can count the numbers. Okay, so the correct answer here is the multiple choice option is there, then FISH and karyotyping are correct. If you want to do the gene sequencing, then go for Sanger sequencing, or you can go for polymerase chain reaction. This will not tell you the aneuploidy. Okay. Next was a image based question. So this was the image that you are supposed to identify, this round eosinophilic structure. Okay. So this is basically a Levy body, which I have shown in my notes also, the rapid revision class also. So that is seen if by the moment you identify this as a Levy body. So this is seen in Levy body dementia. Okay. In Alzheimer's disease, you would see this neuritic plaques. And actually, if you see in my notes, I have mentioned this Levy body under Parkinson's disease, and also I have told that this can be seen in Levy body dementia. Okay, and these are composed of alpha-synuclein, and they are pinkish eosinophilic structure, and you can see that they are closely associated with pigmented neurons, because they usually affect the neurons of substantia nigra. Very, very important. That's in case of Parkinsonism. So remember this structure. So next time you can have an option as Parkinsonism, and this time they have not given it. Okay. So this is a summary in my video lecture, where actually we anticipate such questions, right? So in Alzheimer's disease, you have this neurofibrillary tangles, you have the deposits of this tau protein, and in prion diseases, you have this PRPSC as an abnormal aggregate which is present. In frontotemporal lobar degeneration, you have tau protein, and in Huntington's disease, you have CAG repeats, that is trinucleotide repeats, and in Parkinson's disease, I have mentioned it as Levy bodies. So pay attention, students, and always when these bodies come, go back, look into the images. They are given in the notes, they have shown in the video lectures. You can always remember how do they look, and this comes with repeated revision only. One more, match the following, which is also pretty easy. Negri body, all of you know, that is the rabies, easy option. Again, Levy body came here, that is, here the option is Parkinsonism. Dutcher body, Russell body, plasma cells. So where do you see more plasma cells? Myeloma, multiple myeloma. Michaelis-Guttman bodies are lamellated calcific deposits which you see in macrophages, which are in malakoplakia. Okay, so this is the correct option. Again, a simple recall based match the following question. Naive T cells are converted into CD4 helper T cells by which of the following? Okay, so this expects some kind of deep learning, okay, to answer this question. But if you remember some important logic, then you can answer this question easily. So we have a naive T cell which is not experienced much with the antigen. Now it needs to differentiate, right? Either as Th1, Th2, or T helper 17, or as cytotoxic T cell. It needs to differentiate. So how is it going to differentiate? One is it definitely requires cytokine mediated action. So which are the cytokines which do this role are interleukin 12 and interleukin 6. So they are important. Interaction, they have to meet antigens, right? Then only they are getting stimulated and differentiating. So interaction with antigen presenting cell is also important. Now how are they interacting with antigen presenting cell? The antigen needs to be presented by the antigen presenting cell in association with the MHC molecules, class 1 or class 2, and there has to be co-receptors. So which you have studied as co-receptors, that is CD28, which is there on a T lymphocyte interacting with CD80 ligand on the antigen presenting cell. This has to be there for activation. Now what is which is sounding odd here is the PD1 interacting with PD ligand. Okay, any PD, when it interacts with PD1 or the PDL1, what it does is it blocks the activation. It removes, it sees that the T lymphocyte is not activated and it becomes, it is not able to mount its action against the foreign antigen. So that is what is the role of PDL1, which you have studied as a part of checkpoint inhibitor. So this particular question to answer definitely requires a in-depth learning. So naturally there is no doubt about the last two, interaction with antigen presenting cells and cytokine mediated action. Where you will have a problem is CD28, it is tough to remember. So if we remember the structure here, we have a helper cell here, okay, and then the class 2 MHC molecule which is present here, right? So this is a T cell receptor. These are the different components of this. Whenever there is an antigen presentation, it will recognize only in the presence of when the antigen is presented as a part of class 2 MHC molecule, which is there on all the antigen presenting cells. Now once the antigen is presented, now the CD4 helper cell will start mounting the action only when its co-receptors are engaged. CD28 is which is the one which is present on a helper T cell, and on the antigen presenting cell we have CD80. So when these two are engaged, then only the T cell is going to get activated, that is the helper cell. So this has to be there for differentiation. Okay, so these are the other Th1 cytokines which are released during the inflammation and activation. The other thing that you need to remember is the PD option, which is that is the correct answer in this case. You don't need a PD and PDL1 for differentiation of a naive T cell to active T cell. Rather it inhibits. See here, you can take tumor cell also as an example, or any other cell which express PD1, and it binds to a receptor for PD. Okay, so when we have this binding, what it does when it is engaged, it sees that the cytotoxic T cell or wherever it is, cytotoxic T cell gets inhibited. So this should not happen. This will not help in activation of a naive T cell into an active T cell. Okay, so this is a practical application type of question that they have asked. So you need to be more thorough in basics so that you can answer by the method of exclusion. Next is blood component not obtained by centrifugation. Very, very simple. If you have seen it in my notes, you will definitely answer. So preparation of blood components, I said you need to centrifuge at low speed, centrifuge at high speed. So what are you obtaining in the main bag? You are obtaining the packed red cells, then you are getting platelet rich plasma. From there you are getting platelet concentrate. Again you centrifuge, you are getting the components like fresh frozen plasma and cryoprecipitate. So what have we not shown here is definitely albumin. So albumin is the correct answer in this case. Very, very simple. This time they did not ask you the shelf life that is commonly expected or the transfusion reactions, right? Which of the following is not a feature of hereditary spherocytosis? Pretty straightforward. It's a hemolytic anemia. So there is shortened lifespan. There are spirocytes. What spirocytes? Of course, the microspirocytes. Microspirocytes are there in this. The family history is always there. It is autosomal dominant in nature. Is it associated with G6PD? No, they are different entities, and of course your hereditary spherocytosis is associated with ankyrin and spectrin defects and not with G6PD deficiency. Lastly, patient with umbilical stump bleeding and a positive urea clot solubility test. What is the diagnosis? Sometimes we are so lucky that this is the MCQ that we have in the app. Okay, look at the history now. There is a history of bleeding from the umbilical cord stump. It's a neonate, and the coagulation profile, platelet count, everything is normal. We have put here as clot solubility test. We have not put it as urea clot solubility test. Both are same. Now, what is the factor deficiency is asked. What is the correct answer here is factor 13 deficiency, and we have given even the explanation. Clot solubility test is only done in the setting of factor 13 deficiency. Okay, a positive clot test indicates that the clot has dissolved. So positive result is obtained when the factor 13 is deficient. That is a very short explanation which is given. And when you have solved this MCQ and when you get exactly the same question in the exam, you are the luckiest. And here you have the option, that is factor 13 deficiency. So moment you know that this is Leiden mutation, we are not talking about it. And Gray-Pudlak syndrome, where the storage pool defect is there, and I think I have not discussed that in depth, but this is the straightforward. You already know a knowledge, you have a knowledge that urea clot solubility test is positive, and the answer is factor 13 deficiency. So with that, I would again say that if you are reading the notes, if you are reading the MCQs which are provided by us, and also if you are thorough with your basic knowledge, okay, and if you have viewed the video lectures enough number of times, you can definitely be successful in this journey. If not today, then definitely for the next time. The strike rate as of now was 31 of 32. So most of the questions are elaborately covered either in the notes or in video lectures or as a part of MCQs. So the entire syllabus is covered. That's again concise, and it's prepared by me, and we have a lot of faculty connects to make the interactive and integrated learning easy. And we also have a lot of tests. You can take these tests because the questions keep repeating. Nothing new can happen. The old remains gold, but that gets polished every new time so that you also polish your knowledge and hit the right option so that you get the best seat that you deserve. So with that, I conclude this session and hope this was fruitful. Please help me in finding out the missing options in some of the questions. And once again, all the very best.